Good morning. Dr. Kinney, can you hear me?
We cannot hear.
Good morning. I see Dr. Sweeney and Dr. Kinney. Good morning.
Good morning, everybody.
Good morning. Let's go to the case number 1.
We can put the slide, case number 1.
We've got it.
The slide is there.
Perfect. We see everything. We see you
right.
on the full screen and the slides on the left.
Good. So this is a 86-year-old male who had a stable angina, referred for a cath a few months ago, history of hypertension, AFib not on any NOVAC, does have systolic heart failure, hyperlipidemia. So you can see the medication he has been taking, not on anticoagulation at all. So what he had, he came for cath, he had significant 95% lesion of the ostial RCA, which we did on 20th of May. If you see the MPI was anterolateral as well as anterior as well as inferior ischemia with a EF of 50%. You see that he had AICD because in the past he did have LV dysfunction for which he received a AICD. Ascending aortic aneurysm with a measurement of 4.6. So now he essentially has the left main as well as 2 vessel disease. So if you go to the next slide, the syntax score of 24. So you know whenever there is left main disease, you have to get a STS score which was 4.12. And based on the new 2017 OC criteria, you can see the next slide, third slide, that he will be M, means doable, PCI is doable. So I'm just going to show you the angios.
So Dr. Kinney, let me just clarify. The syntax score was for the whole thing, not the residual syntax, but the primary syntax score of the entire piece. Is that correct?
This is a residual syntax score of, now let me show you the EF is
show
near
us.
normal.
Yeah.
And this is how the RCA looks now. This is the left side. So the residual syntax score of left main, now this is where we are based on the angiogram.
Wow.
Well, you see that it's a heavy calcium. Left main is calcified. Ostial circ, based on the angiogram, maybe we called it 30 to 50. And you can see our app there, calcific app, just being shown that when you have this kind of a case, when you have calcium, this angiographically, I would say severe calcium. But if we are not sure if the ostial circ is involved or no, what we would do is imaging. So, and then you have significant disease of the LAD, which is mid-LAD disease.
And really subtotally occluded LAD, so very, very complex disease here. So do you, before you take us through your calcific aid, if it's okay, we have this amazing panel, Alex and Yves Louvard especially with the left main. What is your approach with this? And let's just be quick. First and foremost, good EF, no support. Is that correct for the whole panel?
Absolutely. Yeah.
Everybody feels confident, even though it's a pretty big, territory to move ahead without support?
I would say also that technically it doesn't seem to be very complex. So
Technically
no
not
ischemic,
complex.
No ischemic time, so I think we can do.
Okay. Alex, any final comments before we go to the calcific aid?
Well, first of all, I think in a case like that, 86, nobody would send to surgery. So that's one point to start.
Yeah, but
the support, ventricular support, is debatable. You could, because if she was going to use rotablator for the LAD with that kind of slow flow, this I would consider.
Okay, that's interesting. Okay, Dr. Kinney, take us through your calcific aid.
So you can see the calcific aid, which is going through one of the top slideshow there. If you see, as soon as you enter, you will decide what is the tab you need to pick. So here will be left main, because we are going to work on the left main. And already angiographically, we knew that it is significant calcium. So I think there's no need to IVUS the LAD. But we did do the IVUS of the circ. If we can show the IVUS of the circ, you can run the whole IVUS, and then we have some measurements. Ostial circ we got just about 4. So right now I'm wiring the LAD with the fielder fine cross and then changing it to the rota wire. Rota floppy we have ready.
So you had decided that you would go ahead with rotational atherectomy based on the angiographic calcification, or is it your calcific aid that's helping you to get there? Dr. Kinney, why did you decide on rotational atherectomy already on this,
So
even
if
with
you
the
go
slow
through
flow?
the algorithm of calcificate, angiographic, if you see the, are they showing the slides there? of
Yes,
the
yes,
app?
we're seeing
good.
this,
So
we-
you can see that if it is severe angiographic calcium, there's no need to do intravascular ultrasound. But then if you're not sure, you can always confirm with the imaging. What we have written is imaging. Whether you want to do intravascular ultrasound or OCT, all depends what the operator has decided. And then you can, based on the calcium arc, the definition is the same. Anything less than 180 or more than 180 calcium arc. Here definitely I will show you. Are they showing the IVUS?
Yes, yes, we see the IVUS.
So this is ostial left main. Go to the left main itself picture. You will see the 360-degree arc of calcium. Okay,
Yeah.
show the 360-degree arc of calcium. Yes, right there.
Right, can everybody should be appreciating that. Manish Patel on the podium, I know I see you all the way at the end there.
Yeah.
Support, yes, no, rotoblader, yes, no. And then I'll go to Colombo and La Sala.
I think normally you have age 86. I think it's reasonable to do without support, but some could consider it. And then, obviously, I think you're going to have to do some sort of atherectomy. A rotoblader makes sense. Conversation of which type we could have.
Dr. Colombo?
No.
I agree without support, but I will not object to use balloon pump. I think it's a reasonable possibility. I have a question to ask Dr. Kimi. How do you decide between rotablation and orbital atherectomy? We don't have access to orbital in Europe. What makes you decide for rota instead of orbital in this case?
Interesting question by Dr. Colombo, that what makes. So for the LAD, we could probably pick any, whether it is rota or orbital. But I think for orbital, based on our imaging study that we have published comparing rota versus OA with the OCT, you definitely need to have more than 2 quadrants, closer to 3 quadrants of calcium before you want to do orbital atherectomy. But if you go to the left main, since the left main vessel is large, and if you plan to do a larger, atherectomy device, you definitely want a rotational atherectomy rather than orbital atherectomy. Dr. Sharma, you want to comment?
So no, I think the question, one of majority of the time, both can be interchanged. But some cases, particularly when you think you are going to use a 2 bar and above, I would say the rotational atherectomy will be preferred, because maximum with the 1.25 orbital at 120,000 RPM, you'll get a lumen of about 1.7, 1.8, which may be enough many of the time, because it cracks the plaque. But if you have a choice and it's not a very circular calcium, as Dr. Keeney pointed out, it's probably better, because we have seen it's not a circular calcium. You see some edge dissection with orbital atherectomy. But anyway, we are ready here with the what bar size you are selecting here?
1.75.
Yeah.
This 1.75 we are going. So if you can show my hands here to show the Rota Pro, the new Rota Pro device, which will not have the pedal. For us who learned Rota in the past, our left leg is still, keeps working, because looking for the pedal. But for the newer kids who are learning, probably Rota Pro is a good one, because they don't have to work with the leg and the hands. So if you see here, what they have is a Dyna button. You press the Dyna button, so Dyna gets activated. I just want to show you. So, hands. This is the Dyna button.
No, but you're telling them hands. They're not showing it.
Can you show the hands?
Yeah, we see it. We see your hands. Don't worry, guys. If I don't see it, I'll tell you. Keep going. We see it.
Good. So most of the wire is here. What we call, this is now we call a new name called the anaconda for this one. And this is the drip that is there. We have the Dyna button on. So if you want to activate the Dyna, you have to press this button. This is how the Dyna, that's all it is. And if you want to, so when the Dyna is on, even if you want to activate the burr, it will never activate. You see that? So you got to go off Dyna, and now what happens, you can check your speed. So it's 152. So we are ready to go. So we are activating the dyna again. The clip is on, so we are just going to go in.
I think it's important to note that most operators would be a little bit nervous about that slow flow down the LAD and going in with the rotational atherectomy here. Any comments from the panelists as Dr. Kinney brings the burr up to the lesion?
Well, I think it's already has some slow flow. If you look at the first angiogram, it looks like there's TIMI2 flow. That's probably not going to get better. So it's going to have to be very slow, careful advancement and allow for intermittent perfusion.
So in what way are
But we're
you
not-
protecting yourself, Dr. Kinney, with this slow flow to begin with? Did you give some nipride? What's the blood pressure? All of those things.
Blood pressure, I think the hemo is being shown in the center screen, top center screen there. You see the blood pressure just about 110. And we have our nurses, ready with the neosynephrine if at all we need it. So let me just tell you the 3 steps. We still do the 3 steps. So just take out the tension, the Y connector where you can take the tension between the burr and the wire. And what I'm going to do is start burring right from the ostium so that the mid part of the left main is taken care and then go to the LED. Now we'll just see the dyna, final. Good. Off dyna.
And just coming back to the point of the slow flow, in this case, slow flow is because of very calcific 95% LED. Once you open that calcium, that slow flow will not worsen, rather will improve, will decrease. So there will be no more slow flow once you finish the with this calcific rota of the LED.
Okay, so this is a 1.25 burr or 1.5? 1.25?
175.
175. Okay, that is pretty good. Aggressive burring. Any comments on the size of the burr when we first start? I mean, we saw a lot of calcific disease. In the LAD, it was almost 90% and so much calcium. Is anyone worried about that 175 burr? Or you saw how nicely she kind of passed the first lesion and now working towards the LAD. Dr. Samuel?
Yeah,
Matthews?
I totally agree with that. When you have a reduced flow in the LAD, I would be very concerned about starting with the 1.75. Though Dr. Sharma said that after opening the first run of rota, the slow flow position will come down. But if the burr size is 1.75, I think they're opposite. The chances of a slow flow would be higher with the 1.5. I would prefer at least the first run to be 1.25 or 1.5 when the flow is so low.
But you see she's already gone through. Blood pressure looks good. So far, so good, Dr. Kinney. You made your turn around. You're using the floppy, and it looks like you've already gone through the entire lesion. And you see she's going back and forth, slow. It's a slow...
I think we did the lesion will come out now.
Okay, yeah.
Okay.
And the moment of truth will speak for the slow flow now. Blood pressure is good. For those of you who might have been worried about hemodynamic support in this 86-year-old man, I think it's important to think about that. Of course, you always want to have seat belts on. I bet she has a sheath on the other side.
Yes.
Access is ready to go if needed. And I think, look, it's difficult to know who may or may not need it. I probably would have been a little bit nervous about not having Impella support here with rotational atherectomy in an 86-year-old, but I'm not Dr. Kinney. She's much more qualified for these very, very difficult cases.
But Roxana, the point of LV support with Impella, I think if use here will not be against. I mean, many people will use it, and that's the right practice nowadays. That complex lesion, even with a normal ejection fraction. So our threshold is a little high. We still keep that same old protocol of EF of less than 35 for Impella, but rare cases, we can still decide. Look at the flow now.
Wow.
Look at the LED flow.
Wow. Dr.
I want to run through.
I'm going to give you guys a clap. That looks good. So far, so good. Great.
So now I'm taking a fielder wire and I'll wire the LED. Now what is the plan for the circ?
Yeah,
Based
so
on the IVUS
tell
finding.
us, the IVUS finding was a 4.0. What is, Eve, I know you're going to say just go to the LAD and forget about the circ, or am I wrong? Yves Louvard, Bifurcation Club president from European Bifurcation Club.
Sincerely, I've not seen very well the lesion, so I was just discussing with Alexander that maybe the lesion was more tight in the circumflex. So I think we have to look in
Dr.
detail.
Kinney, can you give us a spider shot now after the rotational atherectomy so we can get a good assessment of that bifurcation lesion of the circ before we tell you what you should do there?
And IVUS of the ost of the circ. I
Yeah,
think.
she did.
No, we did. We
She
showed
did.
it to
The
you.
IVUS ostium of the circ was 4-0.
Okay. Show the IVUS again, please, of the osteal circ.
But
Okay,
I always
ready?
like to see after burring what's going on with that circ.
See, you
In a good
really do
spider.
not see the osteal
Looking at
circ
this,
as such.
probably I will go for circ first.
You would go for circ and
Yeah.
to do a mini crush type of a
No,
situation?
no, no, I will do provisional.
Provisional? And put the...
This is my only technique, so.
Oh,
cannot
okay.
say
Your
the
only
same.
technique is provisional.
Doctor,
But, you know, provisional is the wrong name. This is,
Yeah.
of course, we may have to put two stents, but my first step will be a crossover from left main to circ.
Dr. Colombo, before
I
we
will,
ask Dr. Kinney.
I will first predilate, first I will finish on the LED, then I will predilate both the left main, the proximal LED and the circ, and then decide according to the predilatation result. We try not to stent the ostium of the circ if possible, and to use a drug-eluting balloon because the restenosis rate for
okay, we are going to, we'll
double stenting with the
predilate. We have a
ostium of the circ is very
3520
high.
for the LED. The same thing, I think if we go on the calcificate, we will say the same. When you are predilating a calcific lesion, even if you are done atherectomy, after that the balloon size should be 1:1 of the vessel size, so that it will be a NC balloon, 1:1 vessel size, and your dilation pressure has to be 18 to 20, so we know the vessel has really opened up, the lesion has really opened up.
So your number one,
So what was the decision of the panel with regards to circ? I know Dr. Colombo said that take care of the LED, and Dr. Yves Louvard wants provisional stenting.
provisional
we're
stenting
going
into
to
the
now go
circ.
to the LED.
Obviously, you have to take care of the LED lesion first. Then for the
Yeah.
left main, Dr. Louvard believes that given the angiographic appearance of the circumflex, which looks really hazy and not so good, and it's a large vessel, he would like to see you provisionally stent into the circ first and then see what to do. I think we have a mixed result from Dr. Colombo. Take care of the LAD. The question of the left main, please clarify, Dr. Colombo, as Dr. Kinney is deciding what she's going to do. And she'll tell us what she's going to do based on her calcific aid and her own judgment. Dr. Colombo?
But as I said, I think I will dilate the LEDs, the left main and the circ, maybe with cutting balloon for the left main, and then decide after I see the result of predilatation. But I have a very high threshold to stent the ostium of the circ.
So if you
Even if there
really
is a dissection, I do IVUS and decide.
Okay,
Okay.
go. If you saw during rotational atherectomy, I think my biggest time that I was having issue was at the osteal LAD down. So here we are with the 3.5, 18 atmosphere, all the way up to the left main. The left main diameter was,
I think your left
4
main
point.
is a lot larger than a 3.5, obviously.
4.5,
But,
maybe 4.5.
but you see, oh, right there, you see that. That ostium is quite tight.
Yeah, to make your final decision, perhaps an IVUS run into the LAD would also be helpful.
When does your aide say to do another IVUS in the middle of your work? Does it? I don't think it does, right?
no.
I never saw.
IVUS will be at the end.
At the end, I saw that there is very rarely that you need to IVUS unless something extraordinary is happening that you can't explain.
Now you're almost committed to stent the whole LAD because she caused some injury with the 3.5 balloon all the way into the left main.
Okay. No, but with
Yeah,
what?
there's a little dissection there, as you see.
No, LED means up to the left main. We could take one stent, no?
I think you're committed to 2 stents from the LAD into the left main. Dr. Sharma, what's your take
No,
there?
I mean, I know that maybe we can get the vote from our panelists that while the so overwhelming
Go
or
back to the
convincing data of the
osteal
DK crush compared to the provisional stenting, and this was that truly, if you say, based
Maybe
on
the
the
3-5
IVUS and
cutting
even
balloon.
angiographically, it was clearly 60%. So it was 111
Yeah.
lesion. So why would we not do the double stent? My question will be a different way.
Yeah,
Now, why
so-
would you not do the double stent? Maybe people can give a very quick, brief opinion of their one-liner that
Yeah.
what is the against doing 2-stent approach in this particular case,
No,
which
it's a
has a
good-
distal left main 111.
No, it's a great, great, great question. I'm going to start in the back, and Yves Louvard will speak last, since he's, I think, the only one who wants to do provisional work here. But Manish, and then let's just move down.
Yeah,
How
I-
you would approach this.
And then
I
get
think
us the 3-5,
I think
16 right to the
the
circle.
what we would do likely has been heard, which is balloon all 3 and then take a look, or IVUS in the middle. I think the idea is that you do want to try to avoid the ostium of the circ, but it looks pretty diseased here. So I think at that point the decision about 2 versus 1 is going to be made. I do think there's going to be likely a 2-stent technique here, depending on what happens to the ostium of the circ here.
I think
Okay.
because LCX is less than 70 and the osteal lesion is less than 10 millimeters, so provisional also can be considered.
So there's 2 provisional. Next one.
As
Dr.
I
Colombo?
said, I will try to use drug-eluting balloon for the circ and not to stent.
Well, we don't have that here, so what
If you
would you do
don't
then?
have, if you don't have, maybe
12-14.
DK crash.
Okay. Well, they're taking it away from the legs. I don't know when we're going to get it for the arteries here.
hard to get it in the heart.
Altogether.
Yeah.
Yes. Dr. Matthews.
I mean, I would be very, very hesitant to stent the circ ostium unless I have no choice, because we have seen time and again the highest rate of restenosis is osteal circ.
Okay.
Unless I have no choice, I wouldn't stent the circ. I will do everything to
So we are
avoid that.
going 3-5
Okay.
to the circle.
There's
3-5,
no
16.
match you can
Dr.
do
La
with
Sala?
balloon or nothing else.
Yeah, I would agree with trying to avoid the ostium of the circumflex. However, most of the time when I balloon it and then
Wow.
stent over it, I end up
interesting.
putting the stent in the circumflex.
So here's a
think
case
I-
that I actually would say, given what I'm seeing, 2 large vessels, both calcific, and really the circumflex is diseased even just beyond the ostium. You're going to have to do something in that circ. If we're here to do the best complete revascularization, I don't see any other choice but to do a dual stent technique with excellent imaging and final follow-up. But anyway, Alex, and then we'll finish with Dr. Louvard.
So my original plan was to do provisional cross circ, but now that there was a lot of predilatation and preparation in the LAD, I think we're committed with 2 stents.
Yves, you still
know-
want to go with 1 stent?
Provisional is a strategy. It's not a single stenting. This is a first stent, crossover, and then the second stent if you need.
I
And you
see.
can need from 0% to 100%. So we can use provisional, even if you are completely sure that you will put 2 stents. So
Oh,
I see
okay.
the long lesion in the circ. I don't think that can be treated with a balloon, even drug-eluting balloon. I think the lesion in the circ is longer than the LAD, so I will stand from ostium left main to the end of the lesion in the circumflex.
So, Dr.
Probably I
Sharma,
would have not predilated the ostium of the lady after rotablator. And after that, you do a pot, you kiss with a minimal protrusion of the balloon in the LAD, and you look at the result, even with IVUS. That we don't do because we cannot pay it. So.
okay, so I think in all fairness, Dr. Kinney and Dr. Sharma, everyone here is thinking that the strategy of all bifurcation lesions should be a provisional, and then, of course, feeling that with current technology, going to a 2-stent strategy is not an issue at all if needed. But here, I think you're thinking just go straight forward, not waste any time, and move forward because you really feel that this is, and you're very convinced with the DK crush data. Is that right, Dr. Sharma? Dr.
Well, I
Kinney?
mean, other thing is also, as you saw that, the trouble happened in the DK crush, in the provisional stent group, where that 45% requires second
Which is
stent,
a circ.
that group is the bad one. So question is, if you have just a little focal lesion,
sticker?
non-calcific, probably it's okay to go to the stent over, single stent approach, provisional. But if you have this kind of a complex calcific osteal circumflex also, to me, our strategy is, as after the DK crush data with Roxana, you are interviewed and you showed that multiple steps. What we have been doing is the mini crush. And I know
Yeah.
that has been also supported by many other studies. And so that mini crush will give you probably the similar results like DK crush, but less multiple steps. So right now we are ready with the mini crush with a 3.516.
And they will be showing you the steps about app. Keep going. So from calcific app, you can jump to bifurcate app now. Or even the calcific app does have the steps how to do mini crush, DK crush technique.
This is
So
the Promus.
essentially we have a 3, 5, 16 Promus in the circ. We went up to 14 atmospheres, second time quickly. And then what we will do is take out the SDS and the wire from the side branch. We have a 3, 5, 38 in the, from left main to LED already placed.
So that covers your LED lesion as well, because I thought you went a little bit more deeper with your more distal, but let's see what happens. It looks like you got a very
longer. I'm going to pull back now.
because the ostium of the left main has to be covered.
Not the true ostium. I think it's just the body. So you take a cine so that they can see it.
Yeah, show us the cine. So the stent has been placed.
Yeah. So
The
we're going to
wire
go up. Yeah.
removed.
And after this, what we'll do is recross. But then since the left main, this is a 3-5 stent, and the left main is almost 4.2. We'll have to do the pot of the left main, kiss, and then we are going to IVUS at the end. Go up again. Quick, quick, quick.
Okay, so it seems like
So
you're-
right now, what we'll do to recross, because I had a run through in the side branch, which is circ. So I'll likely take the fielder wire, which is in the LED, and go to the circ and use the run through to the LED.
Okay,
Do a swap.
good.
Wire swap. And
You
now
save
let
some
me
money
show
there.
you a picture once we are done. You are ready? Oh, wait. Okay, ready.
Looking good.
So far, so good. That distal edge of the stent and just the outflow, I'm a little bit, it looks a little,
Yeah, that's the way they will look.
Yeah.
We're not going to touch it.
You know,
So-
Roxana, if
Dr.
we looked,
Colombo.
we still did not publish. We needed to publish. When you do 2 stents in the left main, culotte, DK crash, whatever technique, provisional, and then crossover tap, the restenosis rate, if you do late follow-up up to 3 years, is more than 50%. If you don't have restenosis at
50%
1
what?
year, you wait, it will come at 2 or 3 years.
that's interesting
Yeah,
because
but
we're
the
not
LCX
seeing that.
This is
Mainly-
We're
probably
not seeing
mainly
it in
on the
our-
circ.
But
Circ.
let's see who
Yeah.
else has got
And
comments.
it's
Probably.
due to the motion of
Yeah.
the angle.
Was shown by Patrick Saroy that when you are putting 2 stents and the angle is not moving during the systole and diastole. And this is a factor of restenosis.
I mean, it's okay because you
And
have
what
to,
we see also,
to do
even in
something,
longer
but,
time, is neoateroma.
this
And
is a
this is
reality.
probably related to abnormalities of flow.
Yeah, true stress.
So
With-
we're not
with
doing
threats and
routine
so on.
angiographic follow-up, but I can tell you that in our database, these
Okay.
bifurcation
We are
2
going to go
stents
now.
are not restenosing at a
What we
50%
have?
rate. Dr. Sharma, do you want to comment on that? This is what Dr. Colombo and Yves Louvard are saying, that you change the geometry with 2 stents,
And then later, but I
and
was
that eventually there'll be restenosis there.
and you know, I think you're-
Restenosis of the ostium.
Restenosis of that whole system, of the bifurcation system.
Mainly the
In the
LCX
left
you
ostium.
know,
main.
and the truth is that many times the restenosis looks angiographically bad, and if you do FFR is negative. So it's there is this dissociation. You see very focal, short restenosis, and the FFR is 85, 83, some kind of almost negative.
So what I did was a swap. You see that I took the fielder, went to the circumflex, and with the run through went into the LAD. So right now what we'll do is with the kiss of this, we'll do the pot first. We are going to take the left main on the IVUS showed 4.2. So I'm going to take a short 458 millimeter balloon, close to 18 atmosphere for the left main. Do a kiss swing with a high pressure balloon after that, and then we are going to IVUS. I think Dr. Sharma has moved on to the next case.
Yeah, so
Roxana,
let's
if
give
you
us the
can move
next
to room 3
case.
now.
Yeah, let's go to the next case. We'll come back to you. This has been amazing, unbelievable case. So we'll go to Dr. Sharma, and hopefully you'll join him and then show us this final result, because we have 3 cases in the next half an hour. 2 more cases.